I do want to, review, because we touched on it at the very beginning, the carpal tunnel syndrome. I think that's probably a pretty common issue that people deal with. And just so we can kind of review who has it, what causes it, what you can do about it,
Yeah. So carpal tunnel syndrome. So your carpal tunnel, everyone has a carpal tunnel, right? And that's going to be located right here, right at the wrist, the front of the wrist. Very common overuse injury, right? Or pregnant women, right? They have just overall retaining fluid, right? And this carpal tunnel is a very small space, right? You have 9 tendons. Tendons are what control the fingers, right? You have 9 tendons that run through that carpal tunnel, and you have your median
That's
nerve.
like the pulley system that pulls them open and closed.
Right.
Pulls them closed.
Yep. The tendon is what attaches muscle to bone, right? So the muscles are on the forearm, right? And then that turns into a tendon, ultimately goes out to the fingers to help flex the fingers, right? So you have nine tendons and the median nerve going through that carpal tunnel, and there is a little roof to that carpal tunnel. So it's a very tight space, right? So a woman who's pregnant and retaining more fluid, that space might get a little bit tighter, right? Because there's some fluid in there, and that ultimately will press on the nerve, and then everything after the nerve. I like to think of nerves as almost like a garden hose, right? If you step on a garden hose, everything after that is going to be affected, right? So we're compressing the nerve here. Everything that nerve supplies afterwards is going to be affected, which usually a typical carpal tunnel syndrome will present with numbness in the thumb, index, middle, and half of the ring finger, the half on the thumb side, right? So a lot of times patients might say, oh, my hand, when I'm trying to sleep at night, my whole hand goes numb. I say, okay, it's possible, but it's unlikely that it's your whole hand. So next time it happens, we'll do some tests, of course, some provocative tests, try and figure it out during the evaluation. But if I can't reproduce their symptoms, okay, so the next time this happens, really pay attention to it, right? Because is it your whole hand? Is it actually your palm, the back of your hand, your pinky, everything? Because if it is, then it's not carpal tunnel, right? Sometimes they'll come back to me and say, you're right, it wasn't. It was my thumb, index, middle finger, my pinky felt fine. Okay, so then now we know we're talking about the median nerve, which is the nerve that goes through the carpal tunnel, right? Sometimes they may say, oh no, it was really just my pinky, it was just this side of the hand, right? Okay, now we're thinking the ulnar nerve, right? Is it being compressed at the wrist or the elbow, right? But yeah, ultimately, carpal tunnel syndrome, you're thinking thumb, index, middle, half of the ring finger.
So when we've made the diagnosis, so once again, when I've made it in the ER, and I'm proud of myself that I've made hopefully the correct diagnosis, but unfortunately I just say, obviously if someone is pregnant, sometimes it's just taking the fluid off after the pregnancy, right. But also in general, if someone, it's more of a chronic issue, computers, right? So I tend to say, and you can correct me if I'm wrong here, that people are sitting and they don't have the correct wrist support, they're going to make it worse. So it's making sure you have good wrist support at the computer, lifestyle modification, that would be included, NSAIDs and, splinting and follow up with hand. What would be the treatment protocol that you go through?
I think that's all perfect advice. And then, definitely splinting, right? That's in my opinion, the most important thing, because typically with carpal tunnel syndrome, people notice it most at night, right? And they'll say they wake up and their hand is burning and they have to shake it out, and then the symptoms get better, right? So that's usually happening because you're either sleeping with the wrist bent, right? We sleep in all odd positions, right? You sleep with your wrist bent like this, or you sleep with your wrist extended, right? If your wrist is bent, you're putting a lot of pressure on that carpal tunnel, right? If your wrist is extended, you're now stretching that nerve, right? That nerve is traveling a further distance, a longer distance, so you're stretching the nerve. So that what the splint does is it holds you neutral, right? It holds you in this position so that you're not compressing it, you're not stretching it, it just holds it neutral. Splint is usually very effective. And then
now I have to ask on the splint, sorry to interrupt, but because I find, people have sleep apnea when they go to sleep, and some people require BiPAP, CPAP. I'm using my emergency medicine ER language. That's not. Some people have CPAP where, sometimes it's nasal, sometimes through the mouth, but it can look very disconcerting when people see it. And some people don't tolerate it great, but then other people say they have the best sleep of their life. Right. So I'm just curious from a practical standpoint, people who sleep with these wrist splints, what is it comfortable? Is it not? How does that work?
Usually not. It's usually not. Unfortunately, usually splints in general are just not comfortable, right? You're blocking a joint from moving. there's times it will be more comfortable, right? If you have like a thumb arthritis or something like that, right? And moving the thumb in any direction causes pain. Okay, well then blocking that is going to help, right? But sleeping with a wrist brace, it's not easy. And I always tell patients it's not easy, right? There might be nights where you wake up and it's just off. You just subconsciously ripped it off your hand, right? But usually I notice after like a week or so, patients get used to it, and sometimes even quicker than that, they get used to it and they start, making it the whole night wearing the splint. And I also think the benefits, once they start seeing the benefits of using it, that's kind of more motivation to keep wearing it too.
Now, are there any, because I know there's a surgical procedure that people can get that kind of opens up that tunnel a little bit.
Yeah.
What is the general pathway? Do people come to you, and does anyone fail the conservative treatment, and then you have to refer them to a hand specialist?
Yeah.
What happens?
So that part of the reason why earlier in the podcast I mentioned, you feel symptoms, don't ignore it, right? Because the worse you let it get, the less likely it is to respond well to treatment, to conservative treatment, right? If someone comes into me and they have complete atrophy, loss of muscle of their thenar eminence, which are the muscles that control your thumb, and they're saying, oh, I've had a numb hand for 6 years, I already know the chances that we can regain full mobility and sensation in that hand conservatively is very unlikely, right? So usually the more advanced you let the carpal tunnel syndrome get, the less likely it is to respond conservatively. And if that happens, well, typically, if there's muscle loss right off the bat, I'm going to call the doctor and see if they even want to go through a therapy, because it's just very unlikely that therapy is all that's needed at that point. They might need something more. But if they don't respond well to therapy, then we would refer back to the doctor, maybe do a cortisone injection, right? If the cortisone injection doesn't help, then surgery would be the next option.
Mm-hmm.
Yeah.
Staying in the hand region, de Quervain's tenosynovitis.
Yep.
What is it? Who gets it? How do we treat it?
All right, so I'm going to turn this around here. Okay, so can we see this?
You're doing a great job with this disembodied upper arm, by the way. Really tremendous job on camera.
I'm trying. All right, so this de Quervain's tenosynovitis. It's a mouthful, but it's basically when you get significant pain in this area of your wrist, right? So right kind of just before the thumb, right? And a lot of times this is going to can be overuse, right? It can be texting, using your thumbs a lot with the phone, but also new moms lifting babies, right? Because that's how you're going to lift. You're going to put your hands in the underarms, and then the pressure is going to be put on the thumbs, right? So over time, that can kind of cause some irritation in these tendons, and it can be very, very painful.
If we can actually go back to carpal tunnel, because I wanted to bring this up, there are specific tests that one can do to kind of see if they are having carpal tunnel.
Yeah.
From my understanding, the tests from a reproducibility and the likelihood of the test being positive, meaning it's not a one-to-one. It's not everyone who has carpal tunnel, the test is positive.
Right.
And if the test is negative, it doesn't mean you don't have carpal tunnel, right? So what are the tests, and on average, how many people do you see who, the test is positive, they have it, or the test is negative, but they still have it? Yeah.
So there really is like a whole battery of tests, right? And typically if you do a bunch of them, and then, age plays a role, so if they're in the right age range and they're saying nocturnal or nighttime symptoms and they wake up, shaking the hand helps improve the symptoms, those are all, key indicators that it could be carpal tunnel. But a lot of the times what I will do is to know if it's at the wrist, you want to create more pressure at the wrist, right? So these are called provocative tests, right? So you're trying to produce the symptoms. So ultimately, I feel bad because it doesn't feel good, right? But it helps me understand, yes, it is carpal tunnel, or no, it's seeming like it might be something else. So one of the first things I would do is just tap. I'm just tapping right over that carpal tunnel.
That's the Tinel's?
Yes, Tinel's. Yep.
I had to create mnemonics in medical school for all these. So I just remember tap starts with T and Tinel's, so you tap and it reproduces.
Yeah. So so again, it's not 100%, right? But usually when you tap, when you hit that median nerve in the carpal tunnel, they'll feel those electric signals kind of shoot out to the end of their fingers. But that's also, you can do that really for any nerve that's relatively superficial, right? I do that a lot with the cubital tunnel too. That's your funny bone, right? If anyone's ever hit the inside of their elbow on a table and they get that jolt down to their hand, it's not so funny, right? But the way to test for that is tapping there, right? You tap, you feel, I'll feel for the ulnar nerve, find it, tap, and then if they feel those symptoms shooting down to their fingers, then it's indicative of, cubital tunnel syndrome. So yeah, the first one I typically would do is like a Tinel's, right? You can do a Phalen's or modified Phalen's, and that's basically just extreme wrist flexion, right? And you just have them hold that position. So we're just basically putting a lot of pressure on that carpal tunnel, hold it for up to like 60 or so seconds, and say 30 or so seconds in, they say, oh yeah, I'm starting to feel these fingers are going numb. Okay, then it's telling me that the compression site could be right here. Yeah.
And with the Quervains, it's I think the Finkelstein. I had to memorize all these things.
Yeah. So basically putting the thumb in a full palm, or a full fist, I should say, right? And then you're going to ulnarly deviate or put the pinky towards the floor.
Doesn't feel comfortable anyway.
It doesn't.
Yeah,
it's not.
How do you know when it's positive? Because it hurts. A lot.
When I have a patient who's positive, they almost jump out of their seat. It's so painful. Yeah. So it'll be very, very painful when you stretch those tendons that are irritated there.
Gotcha. Yeah. What's the treatment pathway for this?
For Decroveins?
Beyond not lifting kids and just letting them wander on the floor for forever.
Usually splinting, right? Splinting, you want to give it, because in the acute or the early on stages, it can be very, very irritated. So you want to just immobilize it. You can do some range of motion, some exercise throughout the day, but ultimately you want it to be pain-free, right? It's not like a no pain, no gain type of thing. You want to let it rest and heal up a bit. But ultimately you want to it happened for a reason, right? So why did it happen? Was it from lifting the baby? That doesn't mean you can no longer lift your baby, but you have to modify how you're doing it, right? You don't want to put all that pressure on your thumb. So ultimately splinting, right? Some light range of motion, and then over time, once they're able to tolerate more and more, you would want to strengthen those tendons, so they're a little bit stronger and able to withstand whatever you're asking of them.